or the cerebrum consists. Good evening and welcome to today's PLAB-1 discussion class. We're going to be taking central nervous system, and we're going to try to be as apt as possible. Okay, now we're going to talk about the parts of the cerebrum, okay, which includes the frontal lobe, temporal lobe, parietal lobe, and occipital lobe. Like I've described earlier, the frontal lobe is found on the front, like the anterior part of the cerebrum. Then this is the occipital lobe on the posterior part of the cerebrum. This is the temporal lobe by the sides, right? Temporal by the temple by the sides. Then parietal is in between, is in the middle, all right? Parietal, in between the frontal and the occipital. Okay, so each part of the brain has different functions, like central gyrus. This central sulcus, separates the frontal from the parietal. Now, there's something called the Moto Cortex. All right, it's found right at the central sulcus. All right, just before the central sulcus, you find the motor area. Okay, then there is a speech area on the frontal lobe as well, and that speech area is referred to as the motor speech area. Okay, there's another speech area on the temporal lobe, which is referred to as, someone talks to you, for you to be able to understand what the person says, he has to pass through the sensory part of the speech area. Now, for you to respond in kind to what the person said, for you to respond coherently to what the person said, the motor area has to be activated. So speech has both sensory and the motor. Sensory is found in the temporal lobe, all right, while the motor aspect of speech is found in the frontal lobe, the inferior aspect of the frontal lobe, somewhere here, all right. So hearing as well is related to the temporal lobe. Facial recognition, temporal lobe. Then behavior, all right, concentration, problem solving, behavior, and all those things are found in the frontal lobe. So when someone has a frontal lobe lesion, you see the person now begin to have abnormal behavior, changes in behavior, this social disinhibition, all right. The person tends to now be more outgoing, tends to be more outspoken, and just generally doesn't care anymore. Okay, that's frontal lobe for you, because it's like seat of control, concentration. This person loses concentration. So when you do a mini mental state examination, you find that this person can no longer concentrate. Changes in personality, changes in behavior, social disinhibition, and etc. And there will also be affectation of the motor area of speech. Right, so this is the motor cortex. Okay, then the parietal lobe has some things to do. There's a relationship with taste, all right. Relation just on the lower border, almost on the temporal lobe itself. The relationship with taste, and there's this thing that it does. It helps in stereognosis. Like when you hold an object, you'll be able to tell what type of object it is, what size, what shape, and all that, just from holding an object. All right. So that's part of what the speech area, the parietal lobe, caters for. All right. So it also helps you to be able to, be cognizant of the parts of the body and all that. So if someone has a lesion in the parietal lobe, you may now have this like hemi-neglect. All right. Person will be unaware that there's a second half of his body. If you tell him to draw a circle, he will just draw trousers and forget about the other part, right? Or he wants to button a shirt, just buttons one side and leaves the other side. That's hemi-neglect. Then language and reading and all that also has importance in the temporal lobe. Now, the the most important thing about the occipital lobe is that it caters for vision, because it has the calcarine sulcus, which is where the motor area of vision is located. So it's called the visual cortex, right? So all impulses from the retina in the eyes, right, travels through the optic nerve, optic chiasma, optic tract, optic radiation, lenticulate gyrus, lenticular lateral geniculate body. And all those superior colliculus and all that. All right. Eventually, it terminates in the calcarine sulcus, which is where the motor area, the visual cortex is. All right. And without that area, the person will not be able to see, even though the eyes are good, even though the retina is good. All right. Even though the tracts are good, if there's a stroke that affects that area, the person will not be able to see, and is referred to as what do they call it? Cerebral blindness or cortical blindness. Yes, cortical blindness. All right. This person is having impulses, but he cannot see. In fact, he believes that he can see. That's cortical blindness. Even though all evidences point to the fact that he cannot see, but he will still believe that he can see, and he will say that he can see. All right. So that's how that one works. So let's look at all the hemispheres one by one. So there are like two hemispheres. That is, when you divide the brain into two, there are two hemispheres. Okay, one on one side, one on the other side. So there's a right hemisphere and there's a left hemisphere, and they are joined together by corpus callosum, I think. Yes. So I wish I can see a better picture anyway, but usually one of the hemispheres is usually dominant. Okay, in most people, in 70% of people, 70% of persons, all right, the dominant hemisphere is found in the left. Okay, so all left-handed people have the left hemisphere as dominant. Almost all right-handed people have the left hemisphere as dominant. So it's just funny. So it means that most persons will have their left hemisphere as the dominant lobe. So even the left-handed people will still have their left hemisphere as the dominant lobe. That's why when you are taking a history from a stroke patient, the first question after getting their biodata, one of the first questions you ask them is, what is the handedness of this patient? Is this patient a right-handed patient or a left-handed patient? Because it's important for you to assess where this stroke is likely to be. And the dominant hemisphere is usually the one that caters for speech. Remember that speech center is found somewhere in the temporal lobe, all right? But the dominant hemisphere is the center that caters for speech. Okay, so if there's a stroke in the dominant hemisphere, there will likely be an aphasia. Okay, so the right hemisphere is usually non-dominant, and there's one special importance of the right hemisphere because it has to do with the arts, all right, music, creative arts, right? The right hemisphere is creative, while the left hemisphere is logical. Okay, that's the general principle of the hemispheres. Usually non-dominant. There are two areas of speech. Okay, like I mentioned before, there's the motor area of speech, which is found in the lower aspect of the frontal lobe, inferior aspect of the frontal lobe, and the sensory aspect of speech is found in the temporal lobe. Okay, so now the motor area of speech is known as the Broca's area. Frontal lobe is also known as the Broca's area. Okay, so Broca's area is located in the frontal lobe. If affected, patient will have expressive aphasia. Expressive, okay, so there are two types of aphasia. There's expressive, there is sensory aphasia. There's right. Okay, so when a patient has an injury to the frontal lobe, there may be an expressive aphasia or motor aphasia. That means this person understands you. Patient even obeys command. If you say shake my hand, patient will shake you. Close your eyes, open your eyes. Patient will close his eyes and open his eyes. Patient understands you, but he cannot still communicate. He cannot verbalize, cannot vocalize his words as he thinks it. Right? So comprehension is intact, but coherence is lost. Writing and reading are impaired. Difficulty in naming objects. So they have this nominal aphasia, right? They can't remember names. They can't, like, it's just at the tip of their tongues, but they cannot name it. Like what, they tend not to understand or to express themselves correctly. Okay, they're not coherent, but they comprehend. Then in Wernicke's aphasia, reading and writing are relatively maintained. Remember, this is a motor stuff. So writing and reading are impaired, but this one that is not motor is sensory. Reading and writing are relatively intact. Okay, so Wernicke's area is located in the temporal and parietal region. If affected, it causes receptive aphasia. Okay, so opposite of expressive is receptive. Then dysphagia as well. Dysphagia. Aphasia or dysphagia. Okay. Aphasia means there is total inability to speak. Then dysphagia is like partial. Okay. So fast, fluent speech, full of empty words. This person doesn't even understand you. He doesn't comprehend. He's just talking. You know, what we refer in medicine as confabulation. All right. Because the person cannot understand you, he's just making up stuff. Just anything that comes to his head, he will just say it. All right. You may ask him something, he will seem confused because he obviously doesn't even understand you, but he will still say something, all right, that is totally out of what you are even talking about. That tells you that he doesn't even understand you. Okay, but he just keeps saying things. He's fluent, just talking fast, full of empty words. All right, comprehension is lost, but coherence is maintained. Difficulty in understanding, which is comprehension. So dysphasia is a disorder of speech. There are two types. There's nominal dysphasia, there's global aphasia. Okay, so nominal is difficulty in naming objects, which is usually Broca's aphasia. Like we mentioned, like stuff is at the tip of their tongue. They can't verbalize what they want to say. Okay, so eventually they don't say anything. But in Wernicke's aphasia, they're just talking. They're just talking fast. They're fluent, but they're not saying anything. They're not saying anything that is meaningful. Okay, they're just saying things, saying words, using words, but you can't even make a correct sentence. All right. So global aphasia, there's Broca's aphasia and Wernicke's aphasia, where patient cannot understand and cannot even express himself. Okay. Can so when you test it, right, that's global aphasia. There's agraphia. So they just want to define some terms, some abnormalities, right, and the common causes. So agraphia is a disorder of writing. Okay, and like it was mentioned, one of the aphasias is associated with agraphia. So this person cannot read and cannot write. Alexia is inability to read, right? Alexia. Okay. So why agraphia is inability to write. Agraphia, graph, cannot even write, cannot draw. Then Alexia, cannot read. That's a patient that used to read before, that could read before, cannot read and cannot write. So it means when you're thinking of a patient that has stroke, you have to be testing for all these things. You have to give them something to read. You have to give them something to write. Right? So, okay, as when the person is stable enough. Okay. So, remember I would say that in the motor aspect, um, patients can also not read and write. All right. In the Broca's aphasia, one that involves the frontal lobe. Patient can also not read and write. Okay, so they are talking, they are making sense, they understand you, they are talking, but it's kind of slurred speech, all right? You're not, it's not clear. It's as if something is wrong somewhere. Some of the muscles are not, because for you to vocalize and someone understands you and someone your speech is clear, your muscles of speech have to be intact. Even your tongue has to be intact. Even your lips as well, your palate, your soft and hard palate, all of them, your uvula, all of them combine, the walls of your mouth, all of them combine to make sure that speech comes out the way it's supposed to come out. All right. So if anything is wrong somewhere, then your speech will be slurred. So that's what's referred to as dysarthria. So difficulty in articulation. Right. They can talk. They don't have aphasia. All right. They can understand you. They can vocalize. You understand them when they talk, but it's not very clear. It's not very clear. So it's slurred. So that's dysarthria. Difficulty in articulation of speech. Example is found in alcoholics and also in cerebellar problems due to loss of coordination of the muscles of the tongue. Yeah, like I mentioned, you need the muscles around your mouth, your tongue, your lips, everything, uvula, hard palate, soft palate, all of them, they work together to create speech that is coherent and clear. Okay, I'm so sorry you say this screen is blank. Is it still blank? I don't see any reason why it should be blank because it's showing very clearly here. I think probably it's from your network. Well, your network looks good. I don't know why. And I actually restarted the slide just to make you feel among. Anyway, the next disorder of speech is dysphonia. All right, there's disorder of speech, volume. Dysphonia is about the volume. So imagine the microphone. Microphone makes your volume to be louder. Okay, but in dysphonia, there's no microphone, so volume becomes low. Okay, so volume of speech is low. This time around is about the vocal cord, right? So it usually follows laryngitis, recurrent laryngeal nerve palsy. What is the commonest cause of recurrent laryngeal nerve palsy? Or what is the common cause? Let me not say the commonest cause. Um, what is the common cause of recurrent laryngeal nerve palsy? Yeah, thank you. It usually follows the thyroid surgery. When they do a thyroidectomy, okay, all right, it can injure because the current laryngeal nerve it has a very close association to the thyroid. So after thyroidectomy, is one of the things you have to monitor. You have to make sure that the person's tone is still intact, and because it caters to the vocal cords, it's also important because vocal cords are not working right. Then the patient can actually not breathe. Because when the vocal cord is collapsed, imagine if it is bilateral, there's bilateral recurrent laryngeal nerve palsy, then this patient you have to pass an endotracheal tube because there's no other way this patient can get air. Because when the two vocal cords collapse, that's the end. There's no way for respiration to go in. Okay. Then dyspraxia, inability to do complex movements. That's why it's something they call constructional apraxia. That one is found in patients with liver disease, right? Then there's like they cannot. There's constitutional apraxia. There's dressing apraxia. There's gait apraxia. Okay, so inability to do complex movement. Then there's this one they call Doppler Kinesia. Right? I think it's also a form of apraxia. Right? When you tell a patient to do alternating movement, maybe supining and pronating on top of the arm, find that a patient can not do it in patients that have cerebral lesions. You may not be able to do that repetitive, complex, alternating movements. All right. This is the Cortical Kinesia. Then pass pointing, Romberg sign, all those stuff that you do for cerebral lesions. We'll get to that. So Romberg's test performed with the eyes closed. We'll get to that. So unsteadiness of ataxia. Ataxia is basically unsteadiness of gait, lack of balance. All right. So it's like a situation where a patient gets up. It's a disorder of gait, actually. Part of the mental state examination or nervous system examination is the final exam about the gait. We tell the patient to stand up. For example, a patient that has it, dragging one of the, that's the hemiplegic, this will have kind of gait with a patient with cerebral lesions have. Okay, that's where the ataxia comes in. Okay, they have this um, um, gait. We call the waddling gait. Others, for example, a patient that has common peroneal nerve palsy with foot drop, have this high steppage gait, high steppage, they tend to carry their leg up and then stamp it on the floor. High steppage gait. Now, ataxia, unsteadiness is cerebral or eight cranial nerve lesion. Okay. This vestibulocochlear nerve damage together while eyes are closed. All right. Standing with the feet together. All right. The feet together. Usually, you tell them to spread out their arms. Then help support the patient. So him or her to spread her arms to close his or her eyes. So when they close their eyes, if they start falling, okay, then you know that it's a cerebral lesion. All right, because uh, um, if you have an ataxia, you want to know whether medial lemniscus or whether it is from the patient is walking and ataxia, like you know how a patient that took alcohol, a person that takes alcohol, how they fall about, and that's what ataxia looks like. Okay? So the person is just like all over the place, unable to maintain balance, just dragging all over the place, all right, falling, getting up, all those things. All right. So you now tell the person to put the feet together, stand in one place, spread her arm, keep his or her arms apart, okay, while you are at the patient's back. Then eventually you tell the patient to close her eyes. Okay. So if it's sensory, when the eyes are open, the patient will be able to still maintain balance with the eyes open, like if it's dorsal column medial lemniscus. Okay. But if it is cerebellar, all right, nothing there, nothing will help the patient. Nothing will help the patient. So whether the eyes are closed or whether the eyes are open, patient will still be falling. Okay, that's cerebellum. Because it's sensory, you know, the eyes is a sense organ. Okay, so are you still following, Dr. Noya? All right, so we've been talking for 30 minutes. Other causes of ataxia. So ataxia can be sensory, like we mentioned, dorsal column, medial lemniscus, also known as the posterior column, which is associated with the 8th cranial nerve. All right, then the motor ataxia, which is cerebellar ataxia. All right, then Friedreich's ataxia. This one is very important because I've seen some patients that has something like this. Okay, so Friedreich's ataxia is most common cause of early onset hereditary ataxia. It is autosomal recessive. So when you have early onset hereditary ataxia, autosomal recessive, the typical age of onset is 10 to 15 years of age. All right, gait ataxia and kyphoscoliosis are the most common presenting features. So early onset of age, this is like an adolescent. All right, person is already having ataxia at a very young age, and it's autosomal recessive, and there should be evidence of family history, I think, to some extent. And when the person has gait ataxia and kyphoscoliosis, are the most common presenting features. So neurological features include absent ankle jerks or extensor plantars, absent cerebellar ataxia, optic atrophy, spinocerebellar tract degeneration. Other features: hypertrophic obstructive cardiomyopathy, 90% of cases, which is the most common cause of death. Then diabetes mellitus in 10 to 20% of cases. Then the high act palate, all also features of Friedreich's ataxia. Then another cause of ataxia is Meniere's disease, right? Meniere's disease is like a disease of the vestibulocochlear system, okay? The endolymphatic system, to be precise. So the disorder of the inner ear of unknown origin, like idiopathic disorder of the inner ear, characterized by excessive pressure and progressive dilation of the endolymphatic system. It is more common in middle-aged adults, but may be seen at any age. All right. So Meniere's disease is more common in has a similar prevalence in both male and females. Okay. Features, like you expect, there should be features from the vestibular part of the nerve, and there should be features from the cochlear part of the nerve. So there should be features like vertigo, ataxia, inability to maintain balance. All right. So vertigo is very important. Then there should be features from the cochlear like tinnitus, ringing sensation in the ear. All right. Even sometimes hearing loss. Okay. So recurrent episodes of vertigo, tinnitus, hearing loss, which is usually sensory, neural hearing loss. Vertigo is usually the most prominent symptom. Then there's this sensation of ear fullness or pressure, which is now recognized as being common. Other features include nystagmus and a positive Romberg's test. Okay, so episodes last minutes to hours. Okay, typically symptoms are recurrent, positivity. Okay, definite vertigo and tinnitus. Okay, all right, all right. So recurrent DVT, that's good. Deafness, not dizziness, deafness, recurrent DVT, deafness, vertigo, and tinnitus. Because dizziness and vertigo, they are very close relatives, but I don't think you should be using them in the same sense. So it's deafness, vertigo, and tinnitus are the commonest symptoms. So natural history, symptoms resolve in the majority of patients after 5 to 10 years. The majority of patients will be left with a degree of hearing loss, right? So can run a natural course and then resolve by itself in 5 to 10 years, right? But some will be left with, most will be left with a degree of hearing loss after all that. Then psychological distress as well. I think I have a friend that is having this Meniere's disease. Okay, I have a friend that is having this Meniere's disease. So it can cause a lot of psychological distress. Imagine something is just ringing in your ear all the time, it should be very distressing. Then management, ENT assessment is required to confirm the diagnosis. Patients should inform DVLA. Okay? Current advice is to, it's like driving license, whatever, school in the UK. Okay. The current advice is to cease driving until satisfactory control of symptoms is achieved. For acute attacks, you should use buccal or intramuscular chlorperazine, all right? Then prevention, you use beta-histine. Say it may be of benefit in prevention. So beta-histine. And I think antihistamines also help too. Patient with Meniere's disease, imagine having vertigo while you are driving. That's the cause of road traffic accident. So the patient with Meniere's disease should actually not drive until satisfactory control of symptoms is achieved. So when you see a patient having this issue, tell them to inform the DVLA, that's the driving license and association, right? So we move on to brain lesions, all right? Brain lesions, when you're talking about brain lesions, you're talking about whether it is traumatic, inflammatory, neoplastic, metabolic, everything is a brain lesion. Okay, even the ones you can see, the ones that are microscopic and the ones that are macroscopic, ones you can see on CT scan, the ones you may have to do a brain biopsy to see, right? So they are all brain lesions. And depending on the area of the brain where the lesion occurred, you can have different symptoms. Okay, so a lesion occurring in the frontal lobe, for example, will give separate symptoms, usually personality-related symptoms, okay, that will give away. So even before you do an MRI, you already have an idea. You should already have an idea of where the stroke is likely to be coming from, just based off on the location of the stroke. All right. I saw a patient today that had left hemiparesis. Okay, patient had altered sensorium anyway, not perfectly around, and also has seizures. So even before I saw the CT scan that the patient did, I knew that the brain lesion will have to be on the right side of the brain, right? Okay, the brain lesion has to be on the right side, and the patient is right-handed, which also tells me that majority of patients, right, that's not the dominant hemisphere. The majority of right-handed patients, okay, which means that those that patient will likely not come down with aphasia. So the patient could talk, okay, patient could talk, just that the patient was a little bit not so around, doesn't have a perfect GCS, Glasgow Coma score, okay. So that's about that. Effects of lesion on the brain. Lesion can do two things to the brain: causes destruction or compression on the brain. There will be focal neurological signs like weakness of the legs, visual symptoms, dysphagia, sensory loss, okay? And can also cause irritation of the brain and cause functional problems like epilepsy, hallucinations, and delusions, okay? So can have destruction of the brain parenchyma, compression of structures, surrounding structures, even edema. All these things contribute because whenever there's a lesion, the body will try to respond by the process of acute inflammation, and acute inflammation will end up worsening the situation because it will now cause edema. There'll be vasodilation, all right, causing proteins to be dissipated surrounding areas, and inflammatory cells to also leak out of blood vessels, probably that has rupture, with all the ischemia and everything that is going on. There'll be brain swelling and other things around the lesion, trying to contain it, but also helping to increase the intracranial pressure. Okay, so and whenever you see a patient that has an epilepsy, for example, the patient that I talked about ended up actually came with seizures. The patient had this stroke 6 months ago, but it seems he has a repeat stroke as well. Okay, so that's the effects. Focal neurological signs: frontal lobe, temporal lobe, parietal lobe, occipital lobe, cerebellum, cerebellopontine angle. Okay. Now, each aspect of the brain has functions that it caters for, like I mentioned earlier. Okay, so the frontal lobe, if you have an injury to the frontal lobe, you start having personality changes, intellectual impairment, because it's like the area of cognition that you're able to be self-aware, right? Has something to do with the frontal lobe. Your personality itself is stored in that frontal lobe. So you want to chop up the frontal lobe, the person doesn't even know who he is. He has no sense of awareness, sense of personality, and all that. So personality, intellectual impairment, Broca's aphasia, like I mentioned, the speech area, the motor speech area is in the Broca's area, which is found in forgotten the number attached to it. Can you remember? No, yeah, I think we talked about it some time ago. All right, so Broca's area has Brodmann area dash dash dash. Okay, it's the only one. It's like two. Okay, so the mono or hemiparesis. Okay, then urinary incontinence. Remember, it has the motor area, so there will be some paresis involved, either a mono or hemiparesis, upper limb or both upper and lower limb. Okay, then nominal aphasia, and of course, speech and reading will be impaired. And temporal lobe, okay, has a lot to do with memory. Frontal lobe, I also know, has a role in memory as well. So frontal lobe, temporal lobe will lead to amnesia, deja vu, a feeling of familiarity with everything, a feeling of I've been here before, a feeling of I've done this before, right? Okay, I've experienced this before. That's deja vu. That's what the temporal lobe gives. And temporal lobe also caters to taste, so there will be altered tastes, and also the speech area. The sensory speech area is found in the temporal lobe. Okay, so you have this agnosia, loss of perception, upper quadrant anopia. Okay, so upper quadrant anopia is found in temporal lobe lesions. There's this ST segment. ST segment. So superior is associated with temporal lobe, while the inferior is associated with parietal lobe. Superior quadrantanopia share with temporal lobe lesion, while inferior quadrantanopia is associated with parietal lobe lesion, so ST segment. All right, so deja vu. So déjà vu is failure to recognize situations which have been encountered before. Okay, so it's like the opposite of deja vu. Deja vu is something a person hasn't experienced before. He feels like he has done it before. He feels like he's familiar with this experience. It feels like, but déjà vu is something this person has experienced before, but doesn't even remember that he has experienced it before. Remember, there is amnesia, so that may explain the German. He can't recognize situations that he has encountered before as memory loss, essentially. And when it case aphasia, dominant hemisphere. A person with amnesia cannot practice medicine because everything is from your memory. Okay? Everything. Medicine gives you, if like you have to apply what you've done before. So if you've seen something before, you do it again, you see that pattern again, to click in your mind and you take the same action again, maybe with some modifications. But if you have memory loss, amnesia, it should not even click to you that I've done this before. That means you have to be reading your book every single time you see any new patient. You have to go and open your book because everything will be jamming you. All right, temporal lobe, sensory loss. Okay, then asterognosis, like I mentioned, failure to recognize objects by touch. Failure to recognize objects just by touching them. That's so asterognosis, loss of 2-point discrimination. When it gets aphasia, also affected if it's dominant hemisphere, parietal lobe. Then lower quadrantanopia, so the eyes, speech, then all this asterognosis and 2-point discrimination. Okay. Then I also mentioned hemi neglect, all those other sensory symptoms. Then occipital lobe is where you have the homonymous hemianopia. Okay, usually due to unilateral occipital lobe vision. Then cortical blindness is due to bilateral occipital lobe infarction. Patient is blind but does not understand that he's blind. He has no insight to his blindness. So cortical blindness is essentially bilateral. A patient has a bilateral occipital lobe infarction. This person can never see again. Even though he can see, his eyes can see, but his brain can't see. Right? That's the best expression I can find. His eyes can see, but his brain can't see. Because you need both your eyes and your brain to see for you to be able to see. But it's even your brain that inverts the image that your retina sends to your brain is inverted. It's your brain that realigns it. So imagine when your brain cannot even realign the image. It means you'll be seeing the world upside down. Yeah, lack of insight. They don't believe they are blind. Right? They feel they can see, but all evidence points to the fact that they cannot see, but they still think they can see. So, but if it's unilateral occipital lobe vision, patient will have homonymous hemianopia. Then the cerebellum. Cerebellum is involved with coordination of movement and balance. Okay, there are two major areas that are involved with balance. Okay, the cerebellum is one, and the dorsal column medial lemniscus. That's why you test for joint position sense, vibration, all those things that you test for when you are testing for dorsal column lesions. Okay, so all those things is actually telling you that when a patient has ataxia, you want to know, is it motor or sensory? If it's motor, it's cerebellar. If it's sensory, it is differentiates those two because their symptoms are very, very similar. All right. So in cerebral lesions, patient can have nystagmus because, of course, it also coordinates the eye movements and all that. You're able to turn your eye to follow impulses, or your gaze follows, the two eyes coordinate and follow each other and all that. It's cerebellum that coordinates that. Even for you to be able to stand up, for you to be able to take a walk, and you feel balanced without falling and all that, it's your cerebellum that's taking care of all that. Okay, so person can have double vision, that's diplopia, dizziness, all right, nystagmus, which means the eyes just be mentioned. You cannot say some repetitive words. Okay. Then hypotonia. It's a motor lesion, but it presents like it's a lower motor neuron lesion. So you have this hypotonia. Then past pointing. I mentioned you have to do a finger nose test. Patient will have this past pointing, overshoot. So, for example, send the patient to feed himself, he cannot locate his mouth. He'll be past pointing his mouth, or when you go from finger to the nose, past pointing his nose. Okay, then this local kinesia, you cannot do it. You cannot do that rapid alternating complex movement. Okay, of pronation and supination. Patient cannot do it. Then, of course, you do the standing Bromberg's assessment, then heel shin test as well. It's also a test for this, right? Then, of course, the gait, patient cannot even maintain gait, dancing all over the place as ataxia. Then cerebellopontine lesion. Okay, when there's an injury to the cerebellopontine angle, there will be cerebellar signs. Okay, then cranial nerves. When you see cerebellar signs together with cranial nerves, 5, 7, and 8 lesions affected together. All right, they all pass through that cerebellopontine angle. You have to think of things like acoustic neuroma, right, which is like tumor of the 8 cranial nerves. So when you see nerve 5, 7, and 8, see facial nerve palsy, you see vestibulocochlear not hearing well, okay, vestibulocochlear nerve damage or involvement, okay, and then you see cranial nerve 5, for example, trigeminal area of the face, V1, V2, V3, and then cannot feel very well on the face. You have to suspect cerebellopontine angle. Okay, yeah, loss of corneal reflex is also there. Also nerve 5, attached to the corneal reflex. Especially V1, that's the ocular. The branch of the trigeminal nerve, the first branch of the trigeminal nerve. Okay? Ophthalmic branch, trigeminal nerve. So next, we'll talk about the cortical spinal tract, but we'll have to leave that for the next day's discussion, right? Spinal tract, because it's a very large topic by itself, and because it goes from the cortex, that's the cerebral cortex, to the spine, right? So that's the actual upper motor neuron lesion. So upper motor neuron just talks about lesions that either happened in the cortex or happened along the tract from the cortex to the spinal cord and ends on the anterior horn cells. Okay, so from the anterior horn cells down to the nerve roots, down to the peripheral nerves, down to the musculoskeletal junction is all lower motor neuron lesion. So that's the demarcation. That's why we have to talk about the pyramidal system, all right, which is the motor system, because it helps to tell you what's going on in the brain. So when someone has a lesion, it must not be on the cerebral cortex. It can go and locate, and you know that the pyramidal tract, they pack themselves. They're living, as fibers are living all the cortex, all the cortices of the brain, all the gray matters of the brain. You know, gray matter is where the nerve nuclei and the nerve cell bodies gather, okay, on the cortex, the outside of the brain, okay, on the cortex of the brain. So they all gather there, and eventually they all pack into axons, and all those axons radiate, all of them gather together and squeeze themselves through the internal capsule. Okay, they all squeeze in. So that internal capsule is tightly packed. So when a stroke happens on the internal capsule, it's going to damage a lot of things because a lot of things are packed. So it's just like a bomb that when you throw it in the right place, you destroy massively. Okay, so that will be the introduction to that. And in subsequent classes, we'll try to really go deep, look at the pictures, look at the images of pyramidal tracts, so that it's not just theories, it comes home to roost with us. All right. So that should be the end of this discussion. Let's see how it goes. By tomorrow, we'll have more. Tomorrow should be by 7 because I have so many engagements tomorrow and I need to settle. All right. So thank you for joining the discussion. And I believe we did justice to the topic. All right.